It gives me great pleasure to introduce Dr. Steve Telian, the John Kimmick Professor of Neurotology at the University of Michigan. Steve is a wonderful clinician, a scientist, and a good friend to many of us. And so we appreciate him coming today and giving us a talk on surgery for vestibular disorders. Thank you, Steve.
Thank you, Bill. It's my pleasure to talk with you this morning. This is a topic that I've been interested in for quite a while, and my career in terms of my writing has focused on this topic. The talk today, I'm purposely being fairly reflective, and we'll do some fun things with reverse engineering to make some points that can hopefully involve the fellows if there are more involved here in a few minutes. I have no disclosures pertinent to this. I would like to say happy birthday to Dr. Maxwell. Today is her birthday, and thank her for her hosting of this event over these months, and we wish her well in her new position in Louisiana.
Thank you.
This is my fellow Chris Welch, who is graduating. We had a little truncated ceremony during our Tuesday morning ear conference because we couldn't hold public events. So Chris is going to be staying with us on the faculty. And I would like to add my congratulations to the graduating residents of this year's class, many of whom I had the chance to meet during interview season. And I look forward to watching your careers develop and seeing your contributions to our field. Well, I've become an armchair mountaineer after reading John Krakauer's book 20 years ago on Mount Everest. Since that time, it's become very popular to climb Mount Everest. And this is a photograph of a summit day with good weather, and you can see all the people stacked up wanting to get to the summit. And that's kind of how it is with people who want to talk about cochlear implants and vestibular schwannoma. And I'm kind of the loner over here, like this guy climbing that ice pillar all by himself, talking about vestibular surgery. But I hope I can provide some useful insights. I've written about this topic in the literature. 3 papers I would call to your attention that I think are pretty significant if you've not read them. David Eisenman's fellowship research project studied comparatively vestibular neurectomy and labyrinthectomy patients to look at their vestibular compensation after surgery, and we found no difference. That had been a raging debate in the literature. It's not debated much anymore because we're not doing as much vestibular neurectomy any longer, but that was an important paper. Also, our group has written 2 papers on the use of electrocochleography in diagnosing superior semicircular canal dehiscence, as well as using it for intraoperative monitoring of dehiscence repair. And so those are papers that you might be interested in reading and implementing into your practice. I've also written 17 textbook chapters on vestibular surgery, but only in 6 books, multiple editions, obviously. And I mentioned that only to point out that the surgical videos that I would normally share in a talk like this are available in both the Cummings current edition that just came out and in the Brackman text 4th edition also has the same videos. So if I've left them out of this talk, but if you want to review the videos about the technical aspects of labyrinthectomy and retrolab vestibular neurectomy, those are available to you. So I'll start out with some anecdotal stories about my journey with vestibular surgery. I've been very interested in this topic for years, as I mentioned, and it began in my residency and fellowship, centering around the issue of whether endolymphatic sac surgery should be performed. Two of my residency mentors felt that endolymphatic surgery should never be done, and one of them said it's malpractice to do endolymphatic sac surgery. And so coming out of that residency program where we never saw any, and it was felt to be inappropriate for Meniere's disease, I got to my fellowship experience and we were doing sac operations. And my job as the fellow, as many of yours probably is as well, is to call patients who have questions after surgery. So I was being given the messages from patients with Meniere's disease who'd had an endolymphatic sac surgery, and they wanted to know why they were still having vertigo. So after a few months of this and faking it a bit, I went to talk to Malcolm Graham and John Kemick and said, what should I say to patients who are still struggling with vertigo? And this was what they said: tell them they have to be patient because it takes at least 6 to 12 months for the operation to work. So I did that for the rest of my fellowship, and that worked pretty well. Then John Kemick was giving a talk once about endolymphatic sac surgery, and as most of you know, there's difficulty finding the sac sometimes because in Meniere's disease, it tends to be a contracted area of the mastoid, and sometimes there are complications with the facial nerve or CSF leaks for trying to get in there. So his comment about all that was this: if you can't find the sac, at least be smart enough to stop before you damage something. Then close the wound and tell the patient everything went great. So he didn't want to lose the placebo effect, at least, and I think that's good advice. The only time I've offered a sac a Meniere's patient a sac operation was a very well-informed attorney that I was treating, and every clinic patient visit with him was about 40 minutes long, even if it was a 15-minute slot. And finally he said, you know, I know what you feel about the sac, but I've really decided that that's what I need. And I said, okay, I'd be happy to do that. I can certainly do the operation for you, be happy to do that. He didn't schedule, and then he came back for me to take the stitches out after he went to California and Bill Luxford did his sac operation. And what he said to me is, I went to the House Ear Institute because I felt it was important that the doctor believed in the operation also. So I guess the placebo effect might work both ways. And since he was an attorney, I was just as happy that he did that. And the last quote, I think this is mine, but it might have come from John Kemick. Here in Michigan, a lot of us live in the country, and we have septic fields. And I've never really understood the rationale for a sac operation, but those who've argued that the problem is that the utriculo-endolymphatic valve will agree with this comment: if your toilet is clogged, you don't go outside and dig up the septic field. So this illustrates the controversy, and I don't think I'm going to solve it today, but I will have some comments toward the end, and everyone has to make their own decision about that. The pendulum has swung back and forth over the years. I want to switch now to just some foundational principles that I try to teach to my residents and fellows to help them be successful in making decisions about surgical patient selection in the setting of vertigo. Being able to do the operation is one thing, but doing the operations on the wrong person leads to bad outcomes. So the first principle is surgery for vertigo is almost always elective. The exception being, of course, drop attacks or otolythic crises of Tomarkin. I tell those patients that they should not drive until they've had a labyrinthectomy to resolve those crises. The key considerations in deciding when to do surgery are listed here. I think a well-informed patient should really be able to make the decision if and when to proceed. And it's my habit not to book the surgery on the day of a visit, especially if you're just starting to talk about surgery. I want them to understand the reasons we would offer it to them and what the limitations and risks are, and let them decide based on the impact on their own life in these domains that we've talked about together. And we have to be thoughtful about many of these things too in making our decisions about which operation we would recommend. But fundamentally, it's a lifestyle decision for the patient to try to get their life back on track. And these patients can be among our happiest patients when those decisions are made in a shared decision model and they've come to the conclusion that the time has come. They're also going to bear more responsibility for any difficulties like chronic imbalance from poor compensation afterwards if they didn't feel that they were railroaded into that decision. Second foundational principle, you cannot cure uncompensated peripheral vestibular pathology with surgery if the lesion is stable. And I think this is probably the most overlooked issue in vestibular surgery decisions. So I want to review basically the physiology that you know and think about how that impacts upon this foundational principle. You're all aware of the vestibular hair cells and how the stereocilia are morphologically polarized toward the kinocilium and within the sense organs. When you have deflection toward the kinocilium, you get a depolarization of the cell, which increases the resting discharge in the afferent vestibular neuron. And so this is what the vestibular nucleus is seeing, a change from baseline. And then, of course, it goes back after that deflection ends. And if it goes away from the kinocilium, you get hyperpolarization and a concomitant decrease in the resting discharge that the brain is seeing. If you think about this going on with two ears, physiologic nystagmus in head acceleration really reflects that from ampulopetal flow in the right ear in this illustration, you have increased firing, and in the left ear, ampulofugal flow produces a decrease, and the brain interprets those signals accordingly. So it's up on one side, down on the other, in just the right amounts, and I know what's happening. And of course, I have the nystagmus response from that. In the setting of pathology, when the head is still, you have a mismatch because of the resting discharge and the reduction or absent inputs from the damaged ear. So temporal bone fracture right after a translab operation of any kind, this is the scenario. So you have the mismatch, and you have then spontaneous nystagmus, which is fast phase, VOR to the affected side and fast phase to the opposite side, cold opposite, of course. So what are we getting at when we say stable lesions versus uncompensated lesions? Well, the unstable lesion, the classic unstable ear, is a Meniere's ear, where the patient is fine and then suddenly has vertigo. Something is happening in that labyrinth today at this moment to trigger the spell. And the characteristics of unstable lesions is that these patients are largely normal when they're not having a spell. The vertigo comes on spontaneously, it's episodic and quite intense typically, regardless of the length of the spells. The hearing loss is fluctuating and progressive. in Meniere's disease and in other conditions like autoimmune disease that can cause these kinds of symptoms. They may have a caloric weakness and a phase lead on rotary chair testing. The caloric weakness develops gradually in Meniere's disease. And those are permanent when they develop typically. If you test them between spells, they're going to have minimal nystagmus on their vestibular testing, and their postural control testing will be normal, typically, unless they have chronic symptoms. The stable uncompensated patient is a person who's had a vestibular crisis event, such as labyrinthitis, temporal bone fracture, vestibular neuritis. And these are patients who are coming to see us because they have continued vestibular symptoms, but it's after a vestibular crisis event that happened in the past. And so we have to get that history. We have to ask about the first attack of dizziness they ever had. And if that's the most intense one they've ever had and everything else subsequently has been chronic or associated with head movements, that's an uncompensated stable vestibulopathy and will not generally respond well to surgery. These people may have hearing loss, but it's stable. If they have normal hearing, it's probably vestibular neuritis. They will have a caloric weakness and a phase lead because they've had a significant vestibular injury in the past. And because they're coming to see you and they have symptoms, you would expect some spontaneous and positional nystagmus on the eye movement recordings, and abnormal posturography because they're not well compensated. And so we know that these are signs of poor compensation because when these patients compensate after vestibular rehab interventions, their nystagmus decreases in intensity or goes away, and their postural control can improve or become normal. So these are distinctly different clinical syndromes. And if we don't understand that, we'll make terrible mistakes. How did I learn this? When I came to Michigan, John Kimmich was well known for vestibular neurectomy, and they had already observed that patients with Meniere's disease performed better after surgery than patients with other conditions. And so after we started our vestibular rehab program, we compared the data that we were getting from vestibular rehabilitation for uncompensated vestibular neuritis to vestibular nerve section for that diagnosis. And as you can see, none of the surgical patients reported complete improvement, and only a quarter were meaningfully improved. And of course, they're reporting their improvement to their surgeon. And we all know that when you do that, you have reporting bias. So these results have to be questioned because of reporting bias. And they're not impressive even then. With vestibular rehab, you have a quarter of the patients with no symptoms and half of them having dramatic improvements. So these are really meaningful improvements and way better than surgery. So we stopped doing vestibular neurectomy for uncompensated peripheral pathology at that point. Foundational principle number 3. It's not enough to know how to do the operation. You must make the correct diagnosis. So, like I said, you have to know that you're treating unstable vestibular pathology and you're going to stabilize the disease by ablating function. Which ear is involved has to be, obviously, has to be clear. Which semicircular canal? If you're going to do a canal occlusion, you've got to know which canal is involved. And you have to rule out mass lesions because you don't want to overlook tumors. So let's explore this a little bit, and we're going to do some reverse engineering, as I mentioned. And this is for the fellows, if any are left on the line. Maybe you could turn your audio on and respond. This is a patient that had a bad outcome. He had undergone a labyrinthectomy in the poor hearing ear, which also had significant ipsilateral vestibulopathy on caloric testing. He had a fairly classic history of Meniere spells, but he had no benefit from the operation. Can anyone make a suggestion of how this could happen?
This is Tom Muehlman, one of the House Fellows.
Hi, Tom.
Hi, Dr. Telian. Thanks for the talk. I think, in this patient, it sounds like maybe the operated side could have been burned out and maybe he was developing a contralateral disease.
Exactly right. The patient had begun to have vertigo again, and almost surely it was the other ear. So it's extremely important in this situation to ask the patient, are you having any auditory symptoms associated with your spells in your good ear? And these people are very aware of that because it's their only hearing ear. So this mistake could be easily avoided and should be. Okay, here's another patient who had sequential bilateral posterior semicircular canal occlusions for refractory BPPV and came to us with symptoms unchanged. Should we just quiz Tom all morning?
We should definitely spread it around. There's many other participants. So.
Okay. You can call on one. I can only see a few names up here on my screen.
I mean, you could have this is Ann Maxwell, you could have gotten the wrong semicircular canal. It could be a superior issue or a horizontal canal issue, or they could have, problems with compensation, and now you've removed all their posterior canal input.
Yeah, no, they still had classic BPPV symptomatology. So how would you distinguish posterior canal BPPV from superior canal BPPV on a physical examination?
I mean, with your Dix-Hallpike exam, but.
Yeah, but what are we looking for to distinguish posterior from superior canal BPPV?
The direction of the nystagmus.
What specific aspect?
Whether it's geotropic or ageotropic.
No, that's for horizontal canal. With the vertical canals, you look for the vertical portion of the nystagmus. They're both going to have torsion to the downward ear. And there are some weird variants of posterior canal BPPV that can mimic superior canal, but in the ordinary situation, in posterior canal BPPV, there's going to be an upward component, vertical component to the torsional nystagmus. And it's going to be more obvious in the upper eye. So I don't even look for rotary. I'm expecting that. I'm looking at the upward eye, and I'm looking for a vertical component. And if there's only 2 or 3 beats, it's really important that you see that right away. And that vertical component should be upbeating. And if it isn't, it's downbeating, and it's superior canal. And that's exactly what happened in this patient's case. So they'd lost 2 semicircular canals and still had BPPV. Thankfully, she responded to therapy maneuvers for that, and we didn't have to ablate a 3rd canal. This is a patient who was actually the sister of a friend of mine, and I wish that he had sent her to me earlier. She had already undergone bilateral endolymphatic sac operations for episodic vertigo, bilateral ear fullness, and she also had symmetric borderline normal hearing and a pretty intense anxiety disorder. She was really disabled by reactive depression after these interventions, and couldn't really cope with life at all, and was still having the same attacks she'd had all along. How would that happen?
Could you have the wrong diagnosis?
Yes. What would be the correct diagnosis, probably?
Maybe vestibular migraine?
Yeah, almost certainly. You know, this is a flow sheet that you'd have in a book chapter, for example, but people forget about migraine. And it's probably maybe 5 to 10 times more common than Meniere's disease. So you've got to think about migraine. And if the patient has stable symmetric hearing, you shouldn't really make a diagnosis of Meniere's disease without thinking about migraine and treating that first. Okay, here's a patient who had a SAC operation, and then a shunt revision when the symptoms persisted, and finally a vestibular neurectomy in an ear with a caloric weakness for persisting dizziness after an intense spell of vertigo without hearing loss. He presented to us with suicidal depression and was angry. He had seen 5 prominent neurotologists, 2 of whom had performed these 3 operations, and was very angry with our profession. He himself was a vascular surgeon and couldn't understand how we could botch this so badly when he had bothered to see experts for this.
What's the quality of his dizziness?
It's constant instability, and whenever he would move his head quickly, he would have transient disorientation such that he couldn't even work in an operating room with head movement, disturbing his visual stability. He was not having episodic spells any longer.
Sounds like failure of central compensation.
Yeah, this is an uncompensated patient. And in fairness, this was in the late 1980s before vestibular rehab had been established, and these concepts that I'm talking about have been more widely understood. But you've got a highly symptomatic patient, people are trying to help and doing operations perfectly well, but getting a terrible outcome because of a wrong diagnosis. Lastly, this is a crazy one that I'll share with you. This patient had a classic viral labyrinthitis, and 20 years later developed episodic vertigo, almost surely due to endolymphatic hydrops, delayed endolymphatic hydrops. She went to a physician who believed in perilymphatic fistulas and said, well, you had a fistula, that's why you lost your hearing, and now it's reopened, so we have to repair it. So he repaired the fistula in the right ear, and the dizziness continued. So she had a left perilymphatic fistula repair because he said, well, you're still having vertigo, and he believed that perilymphatic fistulas caused irritative nystagmus. And of course, with a right lesion, she had left beating nystagmus. So he interpreted that as a left PLF repair and did a operation on an only hearing ear, patched the oval window, and the patient had continued symptoms. And he recommended a stapedectomy in the only hearing ear with grafting of the oval window and a piston. And it was only then that she sought a second opinion because she had developed some tinnitus and a little bit of conductive hearing loss from the first operation and was worried about her only hearing ear. And of course, she needed a labyrinthectomy because she had delayed endolymphatic hydrops. So again, the right diagnosis. Early in my career, one of our fellows from England did a study to see which testing indicator most accurately predicted the pathological ear, looking at all variables. And clearly it was the hearing loss. So hearing loss lateralizes the ear in question with the exception of the second ear getting involved in Meniere's disease, of course. And so for high drops, especially, we're looking for a low frequency or flat sensory loss, documented fluctuation, elevated ECOG-SPAP ratio, remembering that ECOG can also be abnormal in superior canal dehiscence. Then there's the issue of overlooking lesions. On the left, you see a vestibular, intra-labyrinthine vestibular schwannoma involving the vestibule and a cochlea in a patient who had had a, quote, normal MRI and was about to have a SAC operation, or was referred for a SAC operation. On the right, this is an ABR done after hours by a gracious audiologist. This patient drove 400 miles from the Upper Peninsula of Michigan to have a SAC operation, but the symptoms were not typical. They were more episodes of disequilibrium lasting hours to days, with some hearing changes and symptoms and an asymmetric hearing loss. But the hearing changes didn't correspond with the dizziness very well. And so, and she had not had imaging. This was again in the 80s. And I'm seeing her for her pre-op visit the night before surgery, and the history wasn't adding up. So I grabbed an audiologist on the way out, and she graciously did this ABR, and we got contrasted CT overnight and found a tumor. So they had a different operation the next day. Again, gotta make sure you see the images yourself. Lastly, foundational principle number 4, we talk a lot about ablating function in unstable ears that will not stabilize, and that's all well and good. And I've listed the ways that you can do that, whether globally with the entire labyrinth or selectively for semicircular canal disorders. But whenever possible, you want to try to improve or stabilize the ear in other ways. And often this is very successful. So as a result of that, we really don't do that much vestibular surgery. This is just a retrospective review of my vestibular operations over my career that I did for the Schindler Lectureship in 2015 at UCSF. And I wanted to see what was happening with the trends of vestibular surgery. Can anyone figure out why I have a peak here? These are 5-year blocks. So even in 5 years, the max labyrinthectomies I did for vertigo would be 26. Why would that peak here and then drop off here?
IT Dex.
Yeah, well, no, actually IT Gent. IT Gent was introduced first, and of course is probably effective in a very high percentage of patients, and so much fewer needing labyrinthectomy. That's right. So I'm getting experience and reputation, and John Kemick died in 1992, so that number's going up, and then started to drop off. And of course, IT steroids may have reduced that even more. Sorry, went backwards by mistake. As you see here, 97 of those labyrinthectomies were done transmastoid, which I prefer. It's more definitive, of course, but these 4 cases are kind of instructive and interesting to people who are experts, so I included them for this talk. 2 of them were cochlear implant patients who had developed dizziness after implant surgery. The first patient developed dizziness, I'm sorry, only one was a cochlear implant patient, I'm wrong. 10 days after surgery, she had the first attack of dizziness, and these were lasting 5 minutes and as long as 3 days. I explored the ear under local and reinforced the cochleostomy site, didn't see a leak there. It didn't work, and 3 months after surgery, I did a transcanal labyrinthectomy, which was successful. And that allowed me to do that without encountering, injuring, removing, and replacing her cochlear implant. And we were able to retain the original device. 2 patients had completion operations after a retrolab vestibular neurectomy. 1 patient presented with persisting vertigo 2 years after his surgery, and the caloric testing suggested a 100% reduced vestibular response. And if you think about it, that would make you think the vertigo is coming from something else. But we know from bilateral vestibulopathy patients that you can have absent calorics and still have vestibular function, because on rotary chair, the gains are preserved. So based on that, I made the recommendation that we would do the transcanal labyrinthectomy to stay out of the surgical bed and not risk a CSF leak, accessing the labyrinth from a transmastoid approach. And this was also effective. The second patient was particularly interesting. He was asymptomatic and presented 26 years after his surgery with new symptoms. And he was describing intense episodic imbalance and falls with ipsilateral ear fullness and sound sensitivity. Curious symptoms, admittedly. And I didn't know for sure whether this would work. His hearing was useless at this point. And so I told him I wasn't sure this operation would work, but it made sense that it might for the same reasons we've just discussed. And these sounded like otolithic symptoms. So if I was right, it should work, and it did. The fourth one was a penetrating foreign body, and I don't know if this really counts, but he had the end of a big pen in his vestibule. This was a psych patient from the VA, and he had poked himself in the ear because of whatever ear symptoms, and the pen came out, but the tip did not, and he was cured of vertigo. Vestibular neurectomy, we see even a bigger drop-off. And in part, this is again because of gentamicin. People prefer an injection even with a higher risk of hearing loss than a major operation. And of course, later steroids and so forth. So I have not done one since this 5-year interval, and the video in the book is the last patient that we did. So I'm glad I took that video. Ways to do vestibular neurectomy if you find yourself needing to do so. Retrosigmoid approach was introduced by Walter Dandy. It's the quickest operation, requires little or no drilling other than the craniectomy. You can section the nerve more distally in the IAC where the vestibular nerves have divided from the cochlear component of the 8th nerve, but this requires intradural drilling. So most people do a sectioning in the cerebellopontine angle. The working distance is very deep, though, for this approach, and I find it off-putting to try to work at that distance and do delicate dissection. Also, this approach is associated with a high risk of chronic headache syndromes, and all the reasons for that are listed there. But these can be very difficult to manage, and for that reason, I don't usually encourage people to pursue retrosigmoid surgery generally. This is a diagram from a book chapter from the Brackman book that Dan Ward, one of my former residents, worked on, and this shows the approach from the suboccipital view with the IAC bone drilled away, and you can see how the 8th nerve is divided and can be selectively sectioned. You have to think about where the nerves are, though, because they rotate. So if you're way out distally in the canal, the facial nerve is anterior superior, as we know, and cochlear is anterior inferior, and the nerves are facing us. And this is the view from a translab approach, of course. But the nerves rotate, and then they become one nerve. So the facial nerve ends up being inferior at the brainstem to the eighth nerve trunk, and travels across it in front of it and gets into this location. And so where you're encountering the nerve does involve where your section is going to be. And of course, if you're in the cerebellopontine angle, you may not have a clear delineation between auditory and vestibular fibers. And that's been known for a long time. This is a paper from the laryngoscope in 1940. Most of us aren't up on that literature. Rasmussen delineated the vestibular fibers from the cochlear fibers, and you can see that there are cleavage planes, and we depend on that. But not all nerves have cleavage planes, and sometimes the cleavage plane doesn't delineate the vestibular fibers completely. So this patient, if you did a superior vestibular neurectomy above the cleavage plane, you'd leave a lot of vestibular fibers. In this patient, if you sectioned randomly, you would cut some auditory fibers and leave some vestibular fibers. So that's why this operation is actually less reliable than a labyrinthectomy in controlling vertigo. The retrolab approach is the one that I was taught and prefer. It was reintroduced in the 80s by the house group, Herb Silverstein and John Kemick, who did most of the publications on this. The advantage is all drilling is extradural, and the nerve is closer to the surgeon when you open in front of the sigmoid. The vertigo control compares favorably to other methods, and you still have the same problem with sectioning the vestibular nerve reliably. The complication rates are acceptable. Middle fossa approach is more technically demanding. So if one isn't doing middle fossa tumor surgery, it probably wouldn't make sense to adopt this for a vestibular neurectomy. One series reported 44% facial nerve paresis in this operation. And when you consider that didn't involve a tumor, that's surprisingly high. It should be low in surgeons with experience doing middle fossa surgery. There's a risk of sensorineural hearing loss, maybe not from damaging the nerve, but probably the blood supply, because you're working out distally in the canal. And what I mean there is, from the middle fossa view, if you section a superior nerve and avulse it, you're going to be looking at transverse crest, inferior nerve, and singular nerve, and the cochlear blood supplies down in there. So if you dig this out, you're risking the blood supply to the cochlea. If you don't, you're risking preserved function in the saccule and the posterior semicircular canal, which could leave the patient with dizziness. In fact, I had a patient with classic BPPV in an ear that had a middle fossa vestibular neurectomy, so they didn't get the ampullary nerve, obviously. Okay, perilymph fistula, a controversy nobody talks about anymore, and I'm glad for that. It was all the rage and in the 80s and 90s. I think most of those patients had SSCD before it was described, and so most neurotologists are not exploring for fistulas unless there's clearly ear trauma or something, barotrauma event where they might think of a fistula. And so I haven't done a fistula repair in many years either. Posterior canal occlusions. A great operation that's needed in some cases. Maybe 1 out of 100 cases of BPPV requires this. The operation was not really described until 1992, and I've had a pretty constant rate, less than one a year over the last 20 plus years. This, of course, renders the ampulla insensitive to stimulation, particularly for canal-lithiasis. Not sure if it would be as effective for cupulolithiasis, and I've never performed it for that indication. Lauren Parnes is the one who's credited really for describing this and assuring us that you could do it safely without hearing loss. And I believe it's indicated if the patient is refractory to multiple repositioning attempts and habituation exercises, regardless of duration. You don't have to wait a year of miserable symptoms if you really aren't making any progress. And of course, if it's a better hearing ear or only hearing ear, that would be a relative contraindication, but I believe it could still be done if necessary. Technically, I like to do this underwater, exposing the posterior canal, skeletonizing it, and then I drill a picture frame around the blue line with a 1 millimeter drill underwater until I start to see cracks around the blue line. And then I'll pick that off, ask my nurse for a Weck cell, and aspirate gently with a Weck cell passively the fluid that I have in the ear and the perilymph. That should allow the membranous canal to collapse, and then we plug with tissue and bone pate that way. You mustn't suck the perilymph because that will lead to damage to the rest of the membranous labyrinth. The only operation, of course, that's increasing in my practice is semicircular canal occlusion for SSCD. I'm relatively conservative about this, and along the way, I started out doing them all middle fossa, and I began to realize around here that in patients with high BMI, and in in migraine sufferers, it was very common to have headache problems after surgery. And so I started preferring the transmastoid approach in that group, and was getting pretty good results. And I didn't realize until I checked my last 5 years subsequently that I hadn't done a middle fossa approach since 2015 for this diagnosis. And I am starting to see some patients who have residual symptoms that I would not expect in the transmastoid group. And so I'm wondering if I've gone too far overboard in that group where we're repairing from below and creating a second defect in the bony labyrinth. For the middle fossa repair,
hey, Steve.
Yeah.
So could you just clarify there? Are you're saying that you're seeing more symptoms in your middle fossa or your transmastoid repairs?
Transmastoid.
Okay. Yeah.
There's the group. The worst clinical scenario is when you have a migrainer who's morbidly obese and also happens to have an SSCD. And the only thing you can really fix is the SSCD, and it's hard to sort out which symptoms may be due to the SSCD, the vestibular symptoms, of course. And so I feel obligated to at least offer them a repair. And if you aggravate their migraine condition, in repairing that, then they've gone backwards. So that's why I went to transmastoid. But I have a few patients that I've plugged, not repaired, not put cartilage over it. I've opened the semicircular canal, plugged it, and spackled it. and I still have, they still have some symptoms, vestibular symptoms, and their ECOG is not normal, post-op ECOG. And I wonder if something's going on there that wasn't happening with the middle fossa approach, where you're repairing it through the defect itself. And so I'm rethinking that, and obviously don't have an answer for you yet. But the canal is not usually this easy to see. This is a very prominent canal sticking up above the rest of the floor of the middle fossa. But the dehiscences are often on the front side or around the back a little bit, and they're hard to find sometimes. And the again, you don't want to suck the perilymph. So this is where intraoperative ECOG is exceedingly helpful. They start out with a high SP-AP ratio, and the minute that you elevate the dura from the dehiscence, even if it's blindly, that SP gets really high and can be even higher than the AP sometimes. And you know immediately that the dehiscence is open, even if you can't see it. So you modulate your surgical approach, and you look you do lots of rinsing and keep the blood out, keep the suction out of the area, and try to visualize the dehiscence before you suctioned in that region. It's really super helpful. And almost always when you achieve adequate plugging, you get an intraoperative correction of the SP-AP ratio into the normal range, demonstrating that you've successfully corrected the disorder. So this is one where I couldn't see around the corner well enough, and this hole was so small that I had to enlarge the dehiscence before I could repair and plug the canal. So here's after the bone pate is in, so that's reconstructed, and then I've taken to putting some bone cement over that, so that area is not at risk from dural contact and development of new symptoms. Endolymphatic sac. We started with that and we'll end with that. As you can see, I've done 4 endolymphatic sac operations in my career, never with happy outcomes, but when I didn't feel I had other good things to offer the patient. I was involved in the Meniere device trial with George Gates. Deb Tusi and I joined as friendly rivals. Doug Green and George Gates were big believers in this, and we thought it seemed like hokum, so we participated. And these were patients who were surgical candidates for SAC or some other intervention, refractory to medical therapy. It was a controlled trial with the device turned off in one group, but they could turn off the pressure without turning off the clicking sound that the patient could hear. The results were actually relatively impressive. The key outcome variable of interest was definitive attacks of vertigo per month. And as you know, anytime you enroll patients in a Meniere's disease study, both groups are going to get better because they're maximally symptomatic. And so we had similar numbers in the control group. They got better over time, meaningfully better. But in the active group, there was always a gap, and at 4 months, this was statistically significant. And so I continue to offer this. Many of the patients, after their condition stabilizes, have donated their devices. And so I have a bank of loaners that I can give out, and people can have a 6-week trial with that device before doing something else. SAC operations. All sorts of things have been done to the SAC. as listed here. Probably the most interesting thing to me that has come out of this literature has been the recent reports from Montreal about duct obliteration, and they show a very nice photo of two clips on the endolymphatic duct. Anatomically, most patients, we're not going to be able to get that kind of exposure. They report results compared to sac decompression that are almost too good to be believed. So wouldn't it be wonderful if we could do a controlled trial of that operation versus a standard sac operation? One of you younger people will have to embrace that opportunity and pursue that to answer this question. Here's my last key quote. When I was the Secretary Treasurer of the AOS, it was my job to review all the CME documentation after the meeting, and two uncontrolled retrospective series of SAC operations had been presented at that meeting. And several people said things like this: I didn't realize endolymphatic sac surgery was so effective. I'm going to start doing it again. So again, the question is, what's the evidence? So we'll finish with a brief review of evidence. The 2013 Cochrane review concluded that there was insufficient evidence of a beneficial effect of endolymphatic sac in Meniere's disease based on the sham surgery study in Denmark and another study from the same group who compared it to inserting a ventilating tube in the ear. The sham surgery is really interesting. This was a study where they had two centers in Denmark that did neurotology, and they blinded the patient and the treating physician to the operation, and they referred the subjects in the study to the other center for their surgery, where they were randomized to mastoidectomy versus sac operation. Then they went back to their provider who cared for them with the patient and the surgeon blinded. I don't think you could do that anymore, but they did it, and it was a very provocative study. Of course, it's not really a placebo if you're doing an active operation. George Gates did a study where just a brief induction of a general anesthetic improved Meniere's disease. So they're having an anesthetic, they're having a temporal bone intervention with drilling, and so there may be a non-specific effect of all that that can induce remissions. So it's not truly a placebo, but the debate was even nevertheless, what should be done? The study showed a 70% success rate at 8 or 9 years after the operation, and two groups, Pillsbury and Welling, did reanalysis and demonstrated that there was a small incremental improvement in tinnitus and hearing loss in the active shunt group. But the main thing was that they had a lasting success rate in both groups. The AAO-HNS guidelines addressed this question, and they said, they ruled that the resolution of symptoms in both groups is a truly remarkable finding, and that the differences between the operations are trivial compared to the magnitude of the overall response. They also took the opportunity to highlight the complexity of the research question, and I'll give you their conclusion on sac surgery in a moment. So what are the guidelines as they relate to Meniere's disease treatment beyond medical therapy? They have recommended against the Meniere device based on a review of 4 studies, including the one I participated in, and they recommend against because they did not find persuasive evidence of benefit over harm. The risk of the Meniere device is limited really to the risk of placing a tympanostomy tube and managing that tube over time during the device use. Most patients only needed one tube. Intratympanic steroid, they do recommend, and intratympanic gentamicin, they did recommend for refractory cases. For surgical interventions, they do recommend labyrinthectomy in those who failed less definitive therapy and have non-usable hearing. And of course, that's been widely accepted for a long time. When it came to endolymphatic sac surgery, the clinical practice guideline makes no recommendation regarding the use of endolymphatic sac decompression due to its uncertain benefit and discordant results when comparing small controlled studies and larger and more numerous uncontrolled studies. So it's not a recommendation against, that's different. And there's a lengthy narrative about this in the guidelines. So I think those who are doing sac surgery would be well served to review that and incorporate that into their counseling of patients should there be a litigation concern subsequently. There's certainly very little strongly in the literature to support sac surgery, and to the extent that practice guidelines and Cochrane reviews matter, it's a problem. Maybe the bigger problem is our failure as neurotologic surgeons to tackle this issue in a thoughtful, multi-center study. And so perhaps the next generation will indeed be able to offer guidance on these questions.